Welcome back to Discussions with Dr. G. Today's episode will focus on the grand viral circus, where the viruses are rowdy, the meds are complicated, and your host tries not to lose her mind explaining why you need to drink 3 liters of water a day. Today, we're kicking things off with the OGs of antiviral therapy, acyclovir and ganciclovir. These are the meds you reach for when herpes simplex or varicella zoster decide to throw a party in your patient's body. And no, before you ask, these will not and do not work on HIV. I know, the names all sound the same after a while, but trust me, your patient with shingles does not need antiretrovirals. So, acyclovir. Think of it as the bouncer for herpes and chickenpox. It's great at kicking out those viral guests, but it's got a bit of a mean streak when it comes to your kidneys. Nephrotoxicity is the big risk here. I always tell my students if you're starting acyclovir, you better have a water bottle glued to your hand. I once had a student who brought in a gallon jug to clinicals and labeled it kidney protection juice. Not wrong. Hydration is your best friend. 3 liters a day, minimum. And if you're giving it IV, slow and steady wins the race. At least an hour, or your patient's veins are going to file a complaint. Now, ganciclovir is the heavy hitter here for cytomegalovirus, especially in immunocompromised folks. But here's the catch. It's not just the virus that gets suppressed. Your patient's bone marrow takes a hit too. We're talking leukopenia, anemia, thrombocytopenia, all the penias. The whole let's make you extra vulnerable package. So, you're monitoring CBCs like your life depends on it. And don't forget, this one is teratogenic. So birth control is an absolute must during and for 3 months after therapy. Bottom line, antivirals are powerful, but they come with their own circus of side effects. Hydrate, monitor, and educate. Those are going to be your 3 magic words. And never ever underestimate the power of the water bottle. Seriously, your kidneys are going to thank you, and so will your patients. Now, let's talk about the real mastermind of viral sabotage, HIV. This virus is like a professional thief with a 6-step heist plan, and every step is a chance for us to throw a wrench in the works. I always tell my students if you can remember the 6 steps of HIV replication, you're halfway to passing pharmacology for HIV. The rest is just surviving the side effects. A little background before we dive into this, okay? A CD4 cell is a type of white blood cell that's also called a T helper cell. It plays a crucial role in the immune system, okay? It helps coordinate the body's defense against infections by signaling other immune cells. In HIV, the virus specifically attacks and destroys CD4 cells. The fewer CD4 cells mean you have a weaker immune system, which leaves the person vulnerable to infections and certain cancers. Okay, here's a quick breakdown, why it matters. CD4 counts tell us how strong the immune system is. Lower counts mean higher risk for opportunistic infections and AIDS. CD4 counts guide when we start or change HIV treatments. HIV infection is diagnosed when someone tests positive for the virus regardless of their CD4 count, okay? AIDS is the advanced stage of HIV and is defined by a CD4 count of less than 200 cells per millimeter cubed, or the presence of certain opportunistic infections or AIDS-defining illnesses, such as like pneumocystitis, pneumonia, or Kaposi's sarcoma, even if the CD4 count is higher. Okay, so HIV means the patient has the virus. AIDS means they have a severely weakened immune system with a CD4 count of less than 200 or serious opportunistic infections. All right. Now that you have a basic background for what HIV is and when AIDS is diagnosed, I want you to picture this. HIV rolls up to the club, trying to fuse with a CD4 cell. This is step 1. First up, we've got fusion inhibitors. And fuviratide is the velvet rope keeping HIV from even getting inside. But of course, here's the kicker. 98% of patients get injection site reactions. 98%! I mean, if you're going to have a side effect, might as well make it memorable, right? Rotate those sites and be ready for some grumbling. Step 2, the CCR5 antagonists. Maraviric is the bouncer who won't even let HIV near the door if it doesn't have the right co-receptor. But watch out for liver issues and dizziness. Always check that your patient's virus is actually CCR5 tropic before you start, or you're just paying a bouncer to guard the wrong door. Then we have reverse transcriptase inhibitors. This is step 3. Nucleoside reverse transcriptase inhibitors, NRTIs, like zidovudine. These are your undercover agents. They pretend to be nucleosides and sneak into the viral machinery, halting DNA construction. But they can cause bone marrow suppression and rarely lactic acidosis. Step 4. Non-nucleoside reverse transcriptase inhibitors, your NNRTIs, like efavirenz, who just block the enzyme outright. No sneaking, just brute force. But the CNS side effects, patients may describe their dreams as like a free LSD trip. Not exactly a selling point, but at least they remembered to take it at bedtime. With step 5 comes the protease inhibitors. My favorite analogy, they're like sabotaging Santa's toy factory. Ritonavir blocks the assembly line, so HIV can't make functional proteins. But the trade-off is metabolic chaos, hyperglycemia, fat redistribution, and a lipid panel that'll make your cardiologist weep. I don't even know on the drug interactions. There are so many. If you are not double-checking every med, you are definitely playing with fire. All right, step 6, integrase inhibitors. Raltegravir. This is the barricade that keeps viral DNA from moving in with your own. No cohabitation allowed. Side effects? Insomnia, headaches, and an occasional rash that you do not want to ignore. Some patients will travel through the whole journey. Start with NRTIs, switch to NNRTIs because of side effects. Then they'll add a protease inhibitor when things get complicated. CNS effects, metabolic changes, the works. It's never a straight line, and every step is a negotiation between viral suppression and tolerable side effects. That's the reality of HIV treatment. Also, it's lifelong, nuanced, and honestly, never boring. So what does this all mean for you, the nurse, on the front lines? 3 words, ready? Adherence, prevention, vigilance. If your patient isn't taking their meds, resistance is just around the corner. Non-adherence equals viral mutiny. You have to be the coach, the cheerleader, and sometimes the drill sergeant. Infection prevention is huge, especially with all the bone marrow suppression going on. Teach your patients hand hygiene like it's your personal crusade. And labs, the labs. CBC for bone marrow, liver enzymes, renal function, lipid panels. If you're not monitoring, you're missing the story. Side effects. Lactic acidosis, injection site drama, and Faviride's 98% reaction rate is no joke. Here's a crocheting analogy to try and make it make more sense. It's like knots and tangles in the yarn, and if you don't keep the pattern tight, the virus finds a way through. Sometimes the best teaching moments come from a ball of yarn and a little creativity. At the end of the day, HIV treatment is a marathon and not a sprint. It takes empathy, education, and relentless follow-up. If you can master these meds and keep your patients safe, you're not just fighting viruses, you're helping people reclaim their lives. All right, that's it for today's Viral Circus. Next time we'll tackle even more pharmacology's wildest battles. Until then, keep your water bottles close and your analogies even closer.